Welcome to our webinar supporting the launch of the Centre's new report, Stability Beyond Care, Why Welfare Matters for Mental Health, which was out last month and can be found on the Centre's website, and we'll also share it in the chat. I'm Shazana Arshad and I work at the Centre. I lead on two networks, which are the Mentally Healthy Councils network, and really pleased to see some of you here today as well, so thanks for joining us. Which the network supports councils with improving the mental health of their communities. I also lead on Equally Well UK, which looks at improving the physical health of people living with severe mental illness. And if anyone's interested in learning more about the networks at the Centre, please do get in touch with myself. Sorry, I had to give that a bit of a plug. During this webinar, we will be sharing key findings from the briefing, which explores the role that financial security, housing stability and access to person-centred advice services play in supporting good mental health and long-term outcomes for people with mental health conditions. So before I continue, do you mind just keeping yourselves on mute? I can hear some kind of background noise. That'd be really helpful. Thank you. I'll shortly be handing over to Andy Bell, the CEO of Centre for Mental Health, who will give an overview of the project and its main findings. And we're absolutely delighted to be joined by Dr. Sue Campbell, who's Chief Executive from Citizens Advice, Winchester District, and John Pritchard, who's the Associate Director of Population and Health Equity from Hampshire and Isle of Wight Healthcare. They'll be giving an overview of the service, its history, development and impact. We'll also get to hear from someone with lived experience who is sharing their story via an audio clip. And we will just give another trigger warning as they will be talking about domestic abuse and suicide. So we'll prompt when the audio is about to start, and we'll also share the helplines again. And then after the presentations, I'll be welcoming and introducing the panelists for the Q&A part of today's session. And I think that's it from me. So without further ado, I'd like to hand over to Andy Bell to make a start. Andy, over to you.
Oh, just unmute, Andy.
Hello. Hopefully this is now working. Can you hear me?
Yes, can hear you clearly.
Yep. Good. Something went horribly wrong there for a moment. I don't know what that was. Thank you very much, everyone, for being here, and thanks, Shazana, for chairing today. My name's Andy. I work with colleagues at Centre for Mental Health, and it's an absolute thrill to share this piece of work with you. It's something that we felt very strongly about for some time. Before I go into any detail, I want to say a massive thank you to the person that did all the work on this, our wonderful colleague Rocio. She's currently on maternity leave, so for obvious reasons won't be sharing her work today, but I wanted to just really thank Rocio for doing this amazing piece of work, and wish her all the best during this crucial time in her life. In the meantime, hopefully you know about Centre for Mental Health already. You're after all here with us, but if you don't, we're an independent charity. We are determined to end inequalities in mental health, and we do that through a whole range of activities, one of which is research just like this. The reason why this is important, well, we have three strategic objectives, one of which is that we all have our basic needs met, so we can all have better mental health, we get the right mental health support when we need it, and none of us experience inequity or injustice because of our mental health. And we know that what we're talking about today could help with all of those and many other things that are really important to colleagues here. So why does welfare advice matter to people with mental health difficulties? Fundamentally, people using mental health services, living with mental health difficulties, face pervasive and systemic injustice and disadvantage throughout life. Injustice and disadvantage often leads to poor mental health, and living with poor mental health means the risk of these things is, if anything, inflated. Here are some of the numbers, most of which will be no surprise to you. But we know from research that we and others have done that around about half of people, based on a survey in the north of England, but it won't be much different anywhere else, are currently living in food poverty with a mental illness. That's an extraordinary health inequality. We know that life expectancy is reduced by 15 to 20 years, and although a lot of that is about physical health, the reasons for poorer physical health often come down to economic and social inequalities. We know that people living with mental illness have very, very high rates of problem debt and other financial difficulties. When this was last measured systematically, which is sadly some time ago now, we know that housing instability was something around about a third of people using secondary mental health services experienced, and employment rates were around about 1 in 10. So these are very systemic inequalities, and we recently last week had the review of personal independence payment, which pointed out how poorly arranged that benefit is for people with mental health difficulties, and that it's not working. And we know many people living with a mental illness face all sorts of difficulties with universal credit, from the poor ways in which the work capability assessment works through to discrimination and the use of conditions and sanctions. So advising people with all these things and many more is really important so that people can assert their rights. Fundamentally, we know that those impacts are felt really significantly, and they have a big effect on people's mental health and well-being. So having difficulties with housing or work or money or any of the other things increase the risk of someone experiencing distress. It can make it more likely you have a relapse of significant mental illness that can put you into a point of crisis and potentially a hospital admission. That's not good for an individual or members of their family, and it's very costly for the NHS and other public services. We know then that being in hospital makes welfare issues more serious. People lose income when they're in hospital, they may lose their job, they may find their benefit entitlements get taken away, which I find extraordinary. Some people end up losing their home while they're in hospital for their mental health, something which I think we have to regard as frankly scandalous. And people who do have debts to pay may find that repayments get missed while they're in hospital. And unsurprisingly, what that means is you then end up staying in hospital for longer, or you may end up being readmitted if those things aren't sorted out while you're in hospital. And again, things just get worse and worse for individuals. And this is a very high cost issue across a whole range of realms. So we're here to focus on the solutions today, and the really good news, the inspiring news, is the work of, I think someone's not got their mute on.
Cheshire East Citizens Advice Bureau North. Yeah.
Sorry, I think someone's not got mute on, if you wouldn't mind. Thank you very much. So we have seen through the research that Rocio carried out 3 amazing examples, and there'll be others here of individuals on this call who are doing similar things, and we're really grateful to you for doing those. We picked out 3 that we came across, which we think are really kind of showing the way. So Sheffield, which has been doing this since the 1970s, yes, the 1970s. Winchester and District working alongside Hampshire and Isle of Wight Mental Health Trust, and Accommodation Concern in Northamptonshire working alongside the NHS Trust there. What we've seen is that each of those work across a wide range of issues. So it's not just money advice. We hear often about calls for money advice in mental health services, and we absolutely endorse that. But it's a whole range of things that people need support with, including health and legal issues, and in terms of health, often dealing with the Mental Health Act. So it's something that you really, that these services work incredibly holistic. They meet the needs people have on the things that really matter to them at the time. Extraordinarily, in Hampshire, we were told that the average client that they work with is dealing with 9 different welfare issues at the same time. And that's the average. That's an extraordinary burden to deal with, of things that are affecting your health and well-being. And crucially, what these services also do is they provide follow-up if you've been in hospital when you leave. And again, we saw in Hampshire that if someone's from another part of the county, they're linked up with their relevant CAB when they go back home, rather than the one that's in Winchester. Really good and interesting and positive practice. We'll hear more about that from Sue and John. So the business case, we need a business case, right? We always need a business case. And here it is. This is a low cost intervention with humongous benefits. The economic evaluation of the Winchester service reckoned that it saves £14 for every one. And that is just for the NHS Trust. Imagine the wider economic and social benefits that this is creating beyond that one organisation. Crucially, service users say they feel better supported and stabilised with this kind of support. Their rights are asserted. Again, in Hampshire, and I know there are calculations in the other places, that each person gained around about £3,000 financially from encountering this service. We know that poverty is a huge risk factor for mental ill health. So tackling poverty and ensuring people get money that they are entitled to, again, in and of itself, is an incredible achievement and will have massive impacts across the country. And so what we can then see is either reduced or shortened hospital admissions. We know that's good for the NHS. Colleagues always like to hear about that. And I think really interestingly, what we didn't expect to hear, but we heard loud and clear, is that having welfare advice embedded and located within a mental health service allows clinical staff to get on with doing their jobs. They're no longer spending hours filling in people's benefit forms or phoning up debtors or other organisations to do jobs that aren't really within their specialism. They're actually able to get on with being health professionals, knowing that welfare advice is there doing its job, helping people with these crucial things. So what did we find matters? Well, you can't just do this any old how. It needs to be high quality. We need providers who are actually expert, like Citizens Advice, like Accommodation Concern, in providing welfare advice that is holistic and person-centred, gives you what you need at the time. Being independent from the NHS is important, given that many people want support around Mental Health Act, for example. That means that there are then contracts that allow for that organisation to work flexibly and to build its infrastructure. Again, not just funding to provide the service, but ensuring that service is well run, that we have an expert welfare advice workforce, people who are properly trained, properly supervised, and who ideally know something about mental health. It's a great job opportunity for people who have some background in mental health but want to do something different, particularly with an aging workforce. That it is tailored to and located within a mental health service. It must be embedded. We know signposting doesn't work. Having Citizens Advice or any other provider in a local area and just saying go off and see them is not the same as having it embedded within the mental health service. If it is, it can work closely with NHS staff, build relationships and ensure that information sharing is facilitated. And we also found that there is an opportunity to test and learn. Delivering might be different in different places depending on what's needed. So if it's so obvious, why haven't we been doing it for a long time? Well, we know that even in the places we looked at, which are really good practice, there are issues with capacity. It is hard to reach everyone who needs it. We know the benefit system often doesn't help. We know that contracting arrangements can be precarious. There are difficulties with governance. And sometimes there just isn't the IT and digital infrastructure within inpatient services in particular. So what do we want to happen? 4 things. First of all, we need dedicated funding, preferably centrally from the government, for all community and inpatient services to embed welfare advice. There needs to be a clear expectation in the modern service framework for serious mental illness that this is part of every service. Some outcome measures relating to these issues, such as housing and work, and that it's commissioned in every neighbourhood by every integrated care board. That's it from me. I shall hand over to Shazana.
Thanks, Andy, and thanks for trying to keep it in time as well. It's probably my fault for not prompting you earlier. Right, so we now have Dr. Sue Campbell and John Pritchard. So can I hand over to you guys?
Yeah, of course. Thanks, Shana. Thanks, Andy, for the introduction. It's really powerful, isn't it, when you put all these things together? Brilliant. I will endeavour to whiz through because I appreciate we're a couple of minutes behind already. But yeah, afternoon, everybody. Yeah, excited to be here and talk about our fantastic partnership that we've got. So we recognised that a significant percentage of our inpatients were spending longer than they needed to in hospital, and that was not because of their mental health diagnosis, but rather because of other factors in their lives that were impacting upon their mental health. Now, these areas of social stress impacted their ability to meaningfully engage in their recovery and their discharge planning, for example. And typically, as Andy has already suggested, the areas of stress would often revolve around debt or finances, issues at work or with family, relationship breakdown, the problem with landlords, legal disputes, all this sort of thing. And now they're all issues that colleagues in our hospitals are not equipped to deal with. Traditionally, their only real option was to signpost to the likes of citizens' advice post-discharge. Now, the evidence was clearly telling us that people didn't go for a whole variety of reasons. And ultimately, whatever their reason, they would probably end up going home and hope that the problem would go away. But of course, it doesn't. It gets bigger and more out of control until the mental health is impacted, and they end up back in hospital again. And we recognised that was a cycle we really desperately needed to break for those people. So Citizens Advice Winchester District secured a small amount of innovation funding from Hampshire County Council to test this new approach of us working together. And our first caseworker started in April 2022, and then frankly, we've never looked back. And we now have the provision across 4 of our acute mental health inpatient sites, 2 inpatient rehab units, and we're just about to expand to our remaining 2 inpatient sites as well, which is fantastic. But the foundation of our partnership is trusted relationships, both between us as partners, but also between the caseworkers and the people they're supporting. The relationships developed through this trust creates a feeling of hopefulness, and that's really important, because that hopefulness kind of gives them a sense that life can be different and better after this admission. And really importantly, the support continues in the community, providing consistency and continuity for people as they transition out of hospital, eroding the cliff face of discharge. And it's well evidenced, as Andy said, well evidenced that people who are more settled are much less likely to need to repeatedly access emergency healthcare or temporary accommodation. Next slide, please, Sue. So as Andy said, there's pockets of really excellent practice right across the country. However, as far as we're aware, apart from one other area who are working to mobilise a similar approach, our embedded partnership is still fairly unique within the mental health space. So consequently, we've always had an eye on the so what factor. What difference is this really making, and how should we evidence it? So over the second half of 2024, we worked with an external health economics organisation who undertook a research study into the model, evaluating its impact. The study itself focused on our first year of working together, carrying out an in-depth analysis of 50 service users who had access to support. Now, crucially, the researchers resampled the data 5,000 times to provide a 95% confidence rating. So that is that they're 95% confident that the results they've established would be replicated across a wider sample size. Now, amazingly, the research concluded that for every £1 we spent on the project, we avoided spending £14.06. That's a significant return on investment. So as we extrapolate that out, the research shows that having the CA service on site meant that we avoided spending nearly £250,000 over a period of about 9 months. And the cost avoidance is largely attributed to shorter inpatient stays, fewer readmissions, reduced medication, and better engagement with community services. That's a staggering amount of money that as an NHS trust we can focus back onto clinical care. Now, whilst important, the economic value that we've just been through represents only part of the outcomes, of course. So Sue is now going to take you through what the equally impressive social impact. So over to you, Sue.
Thank you. I'm just going to run through a few, most of these have already been mentioned, but just wanted to run through a quick thing around the principles that underlie the service. So this set of principles have always been underpinned the model since the beginning, and we've listed them below. Firstly, the advice is holistic, so we focus on supporting the whole person across a range of issues impacting them, such as money, housing, relationships, employment, and so on. We're not prescriptive about what topics we support people with, and co-production is at the core of how the service works. So we sit down with each person and take time to get to know them and the issues they're experiencing, and then work with them to agree when and how we'd address these to meet their goals. This focus on building trusted relationships also extends to staff at all levels. The service is place-based and embedded within NHS services, so it's available where people are. Our caseworkers are familiar faces on the wards and get to know both patients and staff well. This also allows people quick, easy and flexible access to the service. And finally, we also focus on understanding the difference our service makes and learning from that so we can make the biggest difference we can to the people we're seeking to help. So, as I said, from the beginning, we've been really interested in understanding the impact that this service has. And a key part of that is asking people to tell us in their own words what the difference it makes to them. And we wanted to share with you today some of those stories. We're really pleased to say that one young person we've been working with recently was happy to talk to our staff just last week about the difference this has been making to his life. But before we share that with you, I also wanted to bring in the voices of the frontline NHS staff that see the difference this service makes on the ground every day. Over the last 6 months, we've been asking staff in the 4 hospitals where we deliver this service in Hampshire what, if any, difference it's made to them in their own roles. To date, 26 staff have been involved across a range of work roles such as nurses, occupational therapists, support staff, psychologists, ward managers and consultant psychiatrists. We haven't differentiated between these as the sample size is too small at the moment, so obviously some roles are more likely to be directly impacted than others. However, all 26 staff across the sites we spoke to in the last 6 months felt that the service was making a difference on the ward. 15 of these, so around 60%, reported specific improvements to both their workload and their well-being as a result of having the welfare advice service on site. This has been a really interesting but unintended outcome from the service that we've seen since the beginning, that it is making a tangible difference to the NHS staff that the service has delivered alongside. So we asked these 15 people to tell us more about this impact in their own workload and wellbeing in their own words. Most staff described this as related to reduced workload or having more time for their core role or clinical duties. Many also express a general sense of reduced stress, anxiety or pressure from having this additional expertise available on the ward, and the sense of reassurance it gave to them knowing that their patients' needs were being met. I also wanted to share with you the words that 4 staff used to describe the service and its impact. So an activities coordinator in Hollybank in Havant said, "I've learned so much about the important role they play. I'm less stressed and my patients are too. A win-win situation." A matron in Winchester said, "A really vital role, takes work away from an already overstretched nursing staff. Addressing social issues is really important for discharge planning, recovery, etc. It's been great to have the expertise of Citizens Advice." A psychologist, again in Winchester, said, "If an NHS trust is not yet using this model, they don't know what they're missing. It's made a massive difference to Melby Lodge, and I don't know what we'd do without Citizens Advice." And finally, an occupational therapist from Basingstoke said, "I would greatly recommend a Citizens Advice service in any inpatient mental health service. The client population often present with ongoing psychosocial stresses, which can be greatly resolved through working with CA." Finally, and most importantly, we wanted to share the story of just one of the people we've been helping. So I'd like to introduce you to Alex, which is not his real name. We're very grateful to Alex for allowing us to share his story with you today. To protect his anonymity, we've arranged for a volunteer to read the transcript of a phone call that Alex made with one of our staff last week, accompanied by a stock image that you can see. So before I go any further, I just want to give the content warning that we mentioned at the beginning, because Alex talks about some issues such as domestic abuse and suicide. So please feel free to mute or step away for the next few minutes if that would be appropriate for you. Before I share the video clip, the audio clip, I'm just going to give you some brief context. We met Alex when he was an inpatient in an acute mental health unit. He is 19 years old and has experienced a range of adverse events and experiences. Prior to admission, Alex was homeless, following the breakdown of a relationship. Alex has developed a trusted relationship with our caseworker, and over time he has told us that he has 2 key aims in life. These are to have a full-time permanent job and to live in private rented accommodation. Both of these seemed unattainable to him, so our main focus has been on helping Alex to find a pathway to those. We worked through his housing options and the support available to him while he was on the ward. This included creating a plan for short-term accommodation on discharge and advising Alex as he made arrangements to move into a sublet. We helped Alex with the tenancy agreement and are continuing to advise him on his rights as a tenant. We also helped him find sources of support to cover the cost of essentials when he moved in. We've also been helping Alex access other financial support to help him get back on his feet, including ensuring he has income to cover his basic costs and advice on things like sources of clothes for interviews. We continue to support him alongside introducing him to other sources of help, such as the Connect to Work scheme and a local mentoring project for young people. But enough from me, it's time to hear directly from Alex. I'll just pause for a second if anyone wants to leave.
I assume this is to sit there and talk about the work you guys do and how it's actually helping real people. You guys have really saved my life. So yeah, truly. I'd be homeless on the streets if it wasn't for you guys. Literally. So you have actually saved my life in a very important way. Like, I've not personally chosen to take away my life. It got taken away from me through mental health, domestic abuse, and all types. You get me? I lost my life against my will. I'm fighting for this, and you guys really helped me continue fighting, and I would use that as your catchline. Like, having your guys' support with a lot of things that were bringing a lot more strain and stress to my mental health was definitely a very, like, beneficial thing that you guys did. It's given me some kind of confidence to battle life all on my own at 19. So I definitely say it's been rehabilitating, if that's a good use of the word. And the fact that you guys make stuff happen, like nigh on immediately, like most places, you're sitting there waiting months and months to even get a thing. I have one phone call or discussion with you guys, and I get sent 2 emails worth of information. And I'm now getting a full-time job interviews and stuff like that. Like, it's a very, like, yeah, useful, very useful. It's given me a lot of confidence. Like, I'm sitting there, I went from breaking down to the point where I was considering taking my own life to feeling that I actually have a chance at securing myself a private flat one day and starting this job and managing all of this and, like, surviving.
Thank you so much, John and Sue, for sharing that. Really interesting. And I just want to acknowledge kind of the value of lived experience as well, and the case studies that you shared. I think it's so important to make sure that we do work with and co-produce and work with people with lived experience. It's it's at the heart of what we do at Centre for Mental Health as well. So yeah, I just want to acknowledge that and thank Alex for sharing his story as well. So yeah. And thanks for sticking to time as well. We've kind of clawed that back the time. Right, so the next part is that we're going to introduce the panelists. And thank you so much for joining us today. I just want to introduce and welcome Greg Fell, OBE, as the Association of Directors of Public Health President and Director of Public Health for Sheffield City Council. And we also have Kate Bushen, Service Manager from Citizens Advice Sheffield, and also her colleague Peter Ryan from Citizens Advice Sheffield. We also have James Drury, the Director of Strategy at Sheffield Health Partnership University NHS Foundation Trust, and John Perry, who's the MD at Accommodation Concern. So we're going to I'm going to take Chair's prerogative and open it with some questions to the panel. But if anybody does have any questions to ask, please feel free to include it in the chat or raise your virtual hand and we'll get around to all the questions. But I'll kick off with a question that we have prepared for you on the role of advice and support services, which kind of will highlight some of the practical things that attendees can do within their own service. So many people experiencing mental health difficulties also need support with benefits, housing, employment or debt. What role can advice and support services play in improving mental health outcomes? And what examples have you seen of support that has made a meaningful difference to people's lives? This question may be kind of best for Kate Bushen and John Perry from Citizens Advice Sheffield, but feel free to the rest of the panelists if you want to step into that as well.
Hi, shall I go first? Yeah, I'll try and be succinct, but I'm not massively known for being succinct, but I'll try my best. I mean, really just want to echo everything that everybody's said, colleagues in other parts of the country. So our service has been going for quite a good while. It's very different. What we're able to offer at the mental health unit is very different to what the rest of the service can offer. And I think for us, and we were talking about it this morning with some sort of commissioners, it's about the trust. Somebody mentioned the trust, building up the trust. Often you're dealing with people who have got absolutely no support or have been completely let down by the systems, let down by family, friends, even at times, and carers. So I think part of what we really value in Sheffield is that we are able to build up that trust with somebody. We're embedded in the hospital service. We're actually located in the hospital service, and we're able to be really flexible and meet people's needs. And I think that's dead we're dead lucky to have that at the moment, because over the, you know, in terms of funding, we're often restricted. I know colleagues at other LCAs will agree with me. We're often restricted in how we can operate, but actually here we are able to do that client-centered advice. So we are able to offer callbacks, we're able to offer on the ward visits at different times. If we go on to the ward to see a client and a consultant's there, that's fine, we'll leave and we'll come back when it's more convenient. And just to echo, really, somebody said about, you know, the 9 issues, we completely see that as well. We did a bit of research around the number of activities that we do. So our advisors do an activity on or behalf of a client. That means that that client can't do that for themselves, because we will only do an activity, that phone representation letter to a client, if that client is unable to do it for themselves. And when on average for the mental health unit where we work, each client has 14 activities. So that's 14 interventions, if you like, that our welfare rights advisors have done that have progressed that case. And that if had we not been here, what would have happened? You know, they would have been faced with having to try and make an advice line phone call, which we know just doesn't work for a lot of people, but it certainly doesn't work for clients with severe and enduring mental health issues. I'll stop there and let somebody else have a turn. I'm quite happy to carry on, but I'll yeah, be quiet.
No, you took the words out of my mouth, Kate. So yeah, just to reintroduce myself, my name's John. I'm the MD at Accommodation Concern. We're based in Northamptonshire. I think for us, I would sort of look at maybe 3 benefits that this arrangement with our local Foundation Healthcare Trust has brought. And I think for them, it's the ability to start to provide some of that external stability at the point of discharge when people are looking to leave hospital, is that we can be that service that sort of comes in to make sure that they've got a suitable property to be discharged into, and if decisions need to be challenged with local authorities, that we can do that in a pragmatic way and be able to sort of navigate through the systems that are placed. I think the UK is still, despite a lot of the issues that we've got a good, robust safety net compared to lots of other places in the world. The challenge is that safety net is sometimes over here and the client is falling over here, and the services that we've got, sort of advice services, more often than not, are trying to help people to navigate through this really tangled web of support that might be available but has had pressure put on it from all sorts of sides in terms of budget constraints and everything else. I think what the 3 case studies that are involved within this project have shown is that it is possible to make a really compelling argument to the fact that these types of services can actually result in a net saving to the system rather than a cost. And this isn't something that should just be an interesting pilot that gets tacked onto the side of something that a healthcare foundation trust is doing in order to help solve these issues, but actually becomes quite a fundamental part of the offer. And I think the important lesson that we've sort of learned is that from our services point of view is that when we started this arrangement sort of 5 years ago, we weren't quite sure what we were getting into as an advice service. We, were the patients / clients. That's navigating language has been a challenge. We've sort of settled on people in the end, because that kind of goes across everything. But in terms of our service users, immediately breaking the people rule there, we've found that there isn't a huge difference in terms of their ability to engage, in terms of their ability to build that resilience, in terms of their ability to start to take ownership of their own challenges, so that, maybe the first case that we're working with somebody, there's a little bit more hand-holding, there's a little bit more doing that piece of work with them. What we have to be mindful of is also not building that dependency, because advice services have a habit of sometimes being the first professionals that people have dealt with who haven't said no, who haven't closed the door, who haven't had quite a challenging criteria to meet in order to access that support that's available. And that can also lead to challenges around professional boundaries that we need to navigate through with our staff as well to avoid, building that dependency. But it's been a massively positive experience, I think, mainly driven by a very understanding healthcare trust that we've worked with, who have rolled with the punches a little bit in terms of the service delivery as well. Our initial thoughts of how this service might work didn't end up being exactly the same as what it's morphed into over the last 5 years, and having understanding commissioners and understanding professionals that sort of check in enough to make sure that we're on the right track and delivering the right outcomes without being overbearing has been really important too.
Thanks, John, and thanks, Kate, as well, for responding to that. Greg, did you want to come in on that?
Yeah,
question?
I'll just ever so briefly add, I can't talk to the impact on individuals. That's not my space, but I'll find it and I'll put it in the chat. It's worth coming back to the Ben Barr et al. Piece of work led by Liverpool on Liverpool CAB on prescription. It was a primary care based project, but they really went the extra mile and they measured the impact on mental health outcomes. And it was really quite something. I've been waiting 30 years for this particular piece of research. We all believe it, but the Liverpool team actually went to measure the benefit of it. Unsurprisingly, it was cost saving to the health service. There's something in that space to play into. It's a national health service, not a national treatment of illness service, and this plays very, very much into the health bit of that.
Great, thanks, Greg. We have a couple of questions in the chat, and then Ruby will come to you after that, if that's okay. I know some of you have already responded to this question, but I just wanted to see if anybody has anything else to add. So, as a board member of an NHS trust, how would you advise this could be started, instigated? Would this require ICB funding, etc.? And they talk about they're also a trustee of a CA as well. There has been some responses in the chat, but if anybody else has anything to add. If not, then happy to go to the next question. Would be my question for the panel would be on which other mental health services this would be beneficial, for example, perinatal services. And that's open to anybody who cares to respond. James, Greg, is this something that you could respond to?
I think the key development that will be on all our minds in mental health at the moment will be neighbourhood health developments, and particularly learning from the pilots of neighbourhood mental health centres. And Andy's popped in the chat about some of those are already doing this in Sheffield. It will be our ambition to build in the advice elements of that service. What we found in Sheffield is that by being present, by being open, we're getting into a more relational style of engagement with local communities and different conversations with people like tenants and residents associations, for example, that open up the possibility of addressing broader issues like this. That's where I'd like to go, so that this isn't something that can only be accessed when someone's an inpatient, but could potentially be something that helps avoid an admission as well.
Right, thank you. Greg, did you want to come in on that? You've still got your hand up.
Yeah, just to add, I mean, all that James said, I wouldn't be overly thinking about this in the context of specific cohorts of people with specific mental illnesses or any other form of illness, to be frank. There is something about cohort specific and patient specific as critical life events. Acute mental health crisis is one of them. Cancer diagnosis is another. There are plenty of others. But there's also something about sort of being this kind of modality being available for our population, whether that's a population of patients or whether that's a population of residents, is moot. And I genuinely don't think we know which is the best approach to do. And to pick up the earlier question, does this need ICB funding? Not really. It needs funding. Bluntly, I don't care who provides the funding. If ICBs wish to fund it, fantastic. Back to my earlier point, the National Health Service, but it does need resourcing properly. And I didn't know that Sheffield had been in space since the 1970s. I don't think James did either. Did he? We'll see.
Thanks, Greg. Brilliant answer. Ruby, sorry to keep you waiting, but if you want to come in and ask a question, that'd be great.
Hi, everyone. I work as a policy and strategic communications advisor for third sector organisations, public sector, but I also come from a lived experience angle. I'm a burn survivor. I was injured 15 years ago and had very complicated injuries, and I was 22 when it happened. And I just think this is exactly what I've been calling for years, for people that, like you said, Greg, go through massive life incidents, because obviously if you have burns or any traumatic injury, it's got a huge impact on your mental health, both at the time with dealing with your medical needs, but then as you go on, you learn to live a new life, possibly with disability, at least temporarily, and definitely with scars. So I just see the benefits of this, and it mirrors exactly what I've been calling for years. And I just wonder if you know whether these services are embedded in other kinds of NHS services beyond just mental health. If we're looking at a sort of holistic model of how we can support individuals that interact with the NHS, and also to what extent the support is available across a person's lifetime. As someone that lives with PTSD, I'm a productive member of society, but I definitely will need support for the rest of my life. And I think the economic benefits of providing that support are, as you said, multiple. So yeah, I'd just be interested to hear whether this reaches out to other parts of the NHS, and also to what extent someone can draw upon that support across a lifetime.
Thanks, Ruby. Greg, are you happy to respond to that?
I'll have a go. Good question. The Sheffield specific answer, I'm fairly certain, though someone will correct me, that there's citizens' advice in spinal injuries and cancer services. Hopefully someone will nod or shake their head. There's just something specific about everyone wants citizens' advice type services everywhere, all the time, and available to all people at every moment of the day and night. It's just impossible. There are plenty of places where it's well embedded within primary care. And there's a sort of does it have to be on site within the hospital or within the GP surgery, or can it be in the community centre 30 yards down the road, for instance? There's some nuances to go through in that space, as long as it's available is the critical thing. And as I said earlier, I genuinely don't know what the best model is. I don't think we've got any evidence to guide us on that, but colleagues from CA may well have amazing evidence to guide us on that, so I shall shut up now.
Thanks, Greg. And Peter and Kate, do you want to comment on this? And then Claire, I'll bring you in after.
Well, Greg is absolutely right. We do have services in working with patients with cancer. We have a number of different departments in the Children's Hospital where we're present. We are, as you said, spinal injuries. We're also in cystic fibrosis. So there's a lot of different departments where we work in hospital settings. And I think this is definitely a growing role, because once one department finds out about the work, another department suddenly becomes interested in also, repeating it in their own department. So yeah, it's the need is huge, and it is becoming more recognised that we need to be in health settings, or at least be available for the patients of those in those settings with particular referral routes.
Thanks, Peter. Kate, did you want to come in on that?
To be honest, I think Peter's just about said it all. I mean, we've got different models. We're able to be flexible in models, so it depends. Ideally, I think embedded in the different departments at hospitals or the mental health units, wherever, that's, I'd say, the A-star model. But we're also able to provide a service where there is no space in the hospital for us, but we manage to flex that and still provide a service. So I'd say anything's possible. Yeah, I think that's it.
Great, thanks, Kate. And Claire, sorry, I know you've had your hand up for a little while, but do you want to ask a question to the panel?
Thank you. No, it was actually just in terms of responding in terms of where local Citizens Advice are providing advice across different health pathways. And I joined Citizens Advice 10 years ago, working nationally with a brief looking at health. And across England and Wales, there are lots of incredible examples where we're working as part of working supporting people who have specific conditions like COPD, cancer, as was mentioned, working really closely with Macmillan Partnership, but also in the hospital to home pathway. So there's some really, really interesting pieces of work around supporting elderly people to stay safely in their home, in the northeast particularly, but also I can think of some examples of that are also happening in the southeast of services, where actually we're part of that integrated care pathway where people, elderly people are in hospital and are waiting discharge, and how we're removing barriers to ensuring people are able to get home safely. I think one of the interesting things, and it's a two-sided coin, isn't it, in terms of devolution and taking that regionalized approach, is that it allows for lots of development and innovation, but also it does also lead to fragmentation, which I think is one of the main challenges that we see as a national organisation, because we, on a region by region basis, we have incredible services that are making a very meaningful impact, not just to the lives of clients, but also to the health workers, and the amount of time that is spent with people trying to resolve what are non-clinical issues. But it's about how bringing that into a wider picture so that it's seen across the board. That is the challenge.
Thank you. We've got another couple of questions in the chat. There's a question that is a practical one. How did you begin the partnership with each other? Who is best to reach out to within mental health services to get this conversation started? Thanks, Emily, for that question. And that's open to anybody on the panel. Maybe Sue and John, something you can start?
Yeah, so really, I think this partnership was born out of lots of informal conversations at the beginning between at the time that the integrated care boards were being sort of formed. At that time, we started to get people in the same room who discovered that they had lots of similar problems that they were looking at from different angles. So our particular partnership started with a conversation with an assistant director of sort of business partnerships within the healthcare trust, and one conversation led to another, led to a project, led to a pilot, led to a rollout for half the county, led to a taking on the entire county, and as a result of that, the commissioning structure was not as overbearing as it could have been as well, because it was able, they were able to sort of find funding to do things as a pilot and as a contract, and there was benefits not only for the clients, but we built in benefits for sort of NHS staff that were also struggling at the time where the sort of cost of living crisis was really at its peak in terms of fuel costs, etc. I think what we have sort of discovered as we've gone as well is that there's a lot of sort of mutual beneficial elements to this as well. Our cohort of clients that are not covered by our NHS funding have now suddenly got a really quick access. If we need to get a debt and mental health evidence form signed, we've got the right people on speed dial to be able to get that sorted. Or if we need to find an AMP to sign off a mental health breathing space for somebody, we've now got all of these links that are in place. So and I think it's been something where we've started to embed ourselves on some of those wider health determinant meetings that exist as well in things like our transformation pillar meetings, our prevention pillar meetings that happen as a healthcare system, sort of alongside, but also separate to a lot of the work that's happening in our kind of integrated health system with our local area partnership meetings and things like that. So I would say from a advice service point of view, it's making sure that you're at all of the relevant meetings and explaining that your problem is our problem and how can we work together, and also I suppose building that reputation as a trusted partner. AC have been around for sort of 40 years doing this work without this funding, to a much smaller degree, and for us this has helped us sort of go from being an organisation that just very much covered Kettering to now sort of being a county-wide organisation that takes care of the whole county as the sort of go-to provider for this kind of service.
Thanks, Sean. We've got Sue and Catherine, and if they both kind of want to come in on this point, I wasn't sure. Sue, do you want to come in on this point? And Catherine, sorry to keep you waiting. We'll bring you in afterwards.
Yeah, it was just about how do we get it up and running. Just on that question, I completely agree with everything that's been said. I think for us, it was I think a big thing is relationships, has already been said. So the whole thing is about relationships between us and the caseworkers, the people that are trying to help, between the NHS staff and the welfare advice organisation going in, but at all levels. So at the funding commissioning level as well, just building relationships of trust, I think, is really key. Finding the right people, building relationship. John and I met early on, both shared the same passion about getting this service up and running, and I think that's been a real key part of it. Finding people who are passionate about it. And for us, the only way of getting it up and running was to find some innovation funding. So it's really that, either if it comes to the NHS, having people that are willing to take a leap of faith on the voluntary sector, and on all the wealth of evidence that we've seen today, it exists, that it's worth taking a leap of faith on. But it either needs pots of innovation funding outside, or it needs people with that willingness to take that kind of risk appetite approach to innovation within the NHS.
Great, thanks, Sue. Catherine?
Thanks. I'm going to throw in something that I think we need to talk about more in the last 5 minutes, and maybe it's something we can talk about more in a different situation. But I think we've all agreed that this is brilliant and it should be everywhere. And the bit that I'm talking about is it can't be everywhere. And we need to do the piece of work that says, what do we prioritise and where does it go? Because we've talked here about it's really important in an inpatient care setting. It'd be great to have it in integrated neighbourhoods. It'd be great to have it in all population. So, and I think that piece of work, when we're recommending to government, we need to be really clear, because what we've seen around the parity of esteem pace is quite often that people with the most severe mental illness lose out. So is this going to be something that is everywhere, even though we've seen its massive return on investment for those most ill? And I just wanted to say, I think this is something that's great to see Greg on this call, that we need to have more of a public health discussion on, in terms of proportionate universalism. Where do we recommend this? Because the recommendation to say let's have this everywhere is not going to be something that happens. So I think we need to be really clear about where it has to be, where it'd be nice to be, and where that return on investment and cost effectiveness is. And that's something I think we should talk about more.
Great, thank you. I'm just conscious of time. We've got 4 minutes left. Greg, was this a quick one?
Yeah, very briefly, I agree. I'd love to have a conversation. It's just, I don't know where the biggest return. I'm all up for proportionate universalism. If there is evidence to guide us on the where and how, I'm dead up for having that conversation.
Brilliant, thank you. And I'm just going to ask one final question as more of a call to action. So if we want to improve financial security, housing stability, mental health outcomes, what is the most important change that organisations, commissioners or policymakers should prioritise, and why? I guess if we can ask everybody just to make a really quick sentence response to that, that would be really great, and then we can wrap up. If anybody has any response to that, just shout. Greg.
Very quickly, as one of the significant funders of Sheffield Citizens Advice, I will keep it as one of the holy cows. Money's tight. This is one of the things that will go last, and it will not go under my watch, I might add. But it's a sort of just a commitment to doing this stuff because it matters. And a priori, the thing from Ben Barr further up the chart, we know it makes a difference to health, and we know it saves money in the grand scheme of things.
Brilliant. Thanks, Greg. John? Yeah,
thank you. Yeah, just to echo the sentiments of Sheffield, I suppose, across to Hampshire and Isle of Wight. So as I said, we started this with, and Sue said, we started this with some grant funding. That research was so compelling that my board agreed to fund a long-term contract directly to Citizens Advice that we're now funding out of trust reserves, because of the impact it has for our colleagues, our service users, and that economic benefit we've seen. So yeah, absolutely, those right people behind you that keep delivering those results, because they will keep happening, particularly through that trusted relationship approach. I was slightly unpopular with my commercial team, but when we were setting up the contract, specifically didn't put any metrics or KPIs or measurements in that contract, because that's not what this is about. It's about the relationship and those outcomes that are appropriate for the people that are being supported. So it is about doing things slightly differently. It is about trying to blur some of those very traditional NHS boundary lines and sort of morph us more towards the agility and the flexibility of working more with the third sector organisations.
Brilliant. A great way to end there. I'm sorry there are other questions in the chat. We've not had the chance to get to them. We can try and answer them offline, but I just want to thank you, everybody. It was been a really interesting session today. Thanks to all the attendees as well for sparing your time. Thanks to all the speakers and panelists for giving up your time and responding to questions. Please extend our thank you to Alex as well. It was really important and very valued listening to his story. We want to share some links in the chat. I'm getting a bit tongue-tied. Share some links in the chat as well. So there's 3 links coming your way. There's a donation info link. So we are a small charity and we do rely heavily on funding that helps us produce the brilliant work that we are doing. So we'd really appreciate any donation, large or small, that you can make. If you want to sign up to the Centre for Mental Health mailing list, we'll also include a link in the chat where you can receive our monthly newsletter, and that contains lots of updates, kind of all the reports that we're doing and any of events and our blogs, etc. If you want to contact me to join any of the networks, I have included my email in the chat, but I'll add that to the digital good bag as well. And also a feedback form, which really helps us to improve the way we deliver our webinars and make sure they're accessible and meaningful to you all. I'm sorry we've ran a minute over time, but do really appreciate you bearing with us, and really great to see you. Please take care in this heat and enjoy the rest of your day. Thanks, everybody.
Thanks all.
Thank
Take
you.
care.
Take care.
Cheers.
Bye.
Bye.